Hello, everyone, and welcome. Today, we'll be diving into Chapter 47, focusing on the care of patients experiencing musculoskeletal trauma. Let's get started. This chapter is essential because musculoskeletal injuries like fractures and amputations are common across all age groups, especially in trauma situations. As nurses, knowing how to assess and intervene quickly can mean the difference between full recovery and long term disability. Our objectives for this presentation are comprehensive. We'll compare fracture types, discuss bone healing, identify complications, and explore nursing assessments and interventions. We'll also cover amputation management. Let's begin by comparing different fracture types. We'll look at the extent of the break, whether it's complete or incomplete. We'll also examine soft tissue damage, differentiating between open and closed fractures, and discuss various causes like fragility and compression. This diagram illustrates the diverse world of bone fractures. From transverse to comminuted, each type presents unique challenges in treatment and care. Understanding these differences is crucial for effective nursing. Can you identify the fracture type in each image? This exercise will test your understanding of the different fracture patterns we just discussed. Take your time to analyze the shape, angle, and any fragmentation in each image. This kind of visual recognition is crucial in clinical practice, especially when collaborating with physicians during handoffs or reviewing imaging. Now let's delve into the bone healing process. This slide illustrates the formation of cartilaginous and bony calluses, highlighting the continuous stages involved in repairing a fracture. Healing involves several phases: hematoma formation, callus formation, ossification, and remodeling. Healing can be delayed by infection, poor blood flow, or movement at the site, so immobilization and monitoring are essential for success. Fractures can lead to several complications. We'll discuss hemorrhage, compartment syndrome, fat embolism, DVT, infection, skin breakdown, and chronic issues. Recognizing these risks is vital for proactive nursing care. Compartment syndrome is a serious condition. Increased pressure reduces circulation, often due to fractures. Recognizing the common sites and understanding the ischemia-edema cycle are key. This illustration provides a detailed look at acute compartment syndrome. Understanding the anatomy of the leg compartments helps visualize how increased pressure can compromise blood flow and nerve function. Recognizing the signs and symptoms of compartment syndrome is crucial. Pain out of proportion, paresthesia, pallor, and weakened pulse are red flags. Untreated, it can lead to severe consequences. Prompt nursing interventions are essential in managing compartment syndrome. Notify the provider immediately, relieve pressure if possible, avoid elevation and icing, and meticulously document neurovascular status. This slide visually demonstrates the impact of compartment syndrome on the cuff. The fasciotomy diagram illustrates the surgical procedure needed to relieve pressure and restore blood flow. Fasciotomy involves cutting the fascia to release the pressure, leaving the incision open until swelling subsides. Nurses must monitor for infection, bleeding, and provide wound care post-op. This case study highlights the surgical management of compartment syndrome. The fasciotomy allowed the muscle to expand, relieving pressure and enabling the patient to make a full recovery. Without that procedure, the muscle could have died, possibly leading to amputation. This story shows why early recognition and advocacy for your patient are critical nursing roles. Fat emboli are a serious complication, especially after long bone fractures. Recognizing the signs and symptoms, such as tachypnea, confusion, petechial rash, and fever, is critical for early intervention. Slide 15. Diagnostic procedures like ABGs and chest X-rays play a crucial role in confirming fat emboli. Diffuse infiltrates on the X-ray are a key indicator. You might see ground glass opacities or patchy infiltrates on the X-ray, which point to respiratory involvement. ABGs typically show hypoxemia, meaning low oxygen in the blood, which reinforces the need for prompt respiratory support. Laboratory indicators like hypoxemia and thrombocytopenia can also suggest fat emboli. Prevention through early mobilization and effective shock management is paramount. Low platelet counts may be due to the fat triggering an inflammatory response. Preventing fat embolism starts with stabilizing fractures early, minimizing movement, and monitoring high-risk patients closely, especially young adults with long bone fractures. Nursing interventions for fat emboli include oxygen administration, mechanical ventilation with PEEP, optimal fluid replacement, and potentially corticosteroids. When caring for patients with fractures, remember the ABCs. Identify fracture types with high blood loss potential, control bleeding, assess neurovascular status, and immobilize the fracture. The ABCs, airway, breathing, circulation, are your trauma priority. Pelvic and femur fractures can cause massive blood loss, so always assess for signs of shock, including low BP, rapid HR, and cool, clammy skin. In primary assessment, airway is paramount. Can the patient speak? Are there secretions? Can they protect their airway? These questions guide our immediate interventions. A clear airway means the patient is conscious and able to speak. Any obstruction, like blood, vomit, or swelling, requires immediate suctioning or airway protection. Be ready for intubation in cases of facial trauma or unconsciousness. Next, assess breathing. Is the patient breathing spontaneously and adequately? Is there cyanosis? These observations inform our respiratory support. Use your eyes and ears. Watch chest movement, listen to breath sounds, and check for signs like flaring nostrils or use of accessory muscles. Cyanosis, bluish lips, or nail beds is a late sign of hypoxia and should never be ignored. Circulation is the third critical component. Check the pulse, look for uncontrolled bleeding, assess skin condition, and measure blood pressure to evaluate circulatory status. Exposure is essential to identify all injuries. However, remember to keep the patient warm to prevent hypothermia. Secondary assessment involves vital signs, comfort measures, a thorough history, a head-to-toe examination, and inspection of posterior surfaces. The head-to-toe assessment is a systematic approach. Assess neurological status, injuries to the head and face, and carefully examine the neck for any signs of trauma. Continue the assessment, evaluating the chest, abdomen, extremities, joints, and posterior surface for tenderness, swelling, and other abnormalities. Neurovascular assessment, or CMS, is crucial. Evaluate skin color and temperature, peripheral pulses, capillary refill, movement, sensation, and pain. Remember to assess peripheral pulses at key locations: radial, brachial, femoral, posterior tibial, and dorsal pedis. Use Doppler if you can't feel the pulse. Marking the pulse location with a skin pen helps you track changes. Absence of a pulse is a surgical emergency, so document and report immediately. Ongoing assessment is vital. Understand the mechanism of injury, anticipate complications, seek out new injuries, and always prioritize the ABCs. This illustration highlights the signs of acute arterial occlusion or limb ischemia: pain, pallor, pulselessness, paralysis, paresthesias, and polar cold. This slide provides a visual representation of arterial occlusion, emphasizing the importance of recognizing the signs and acting quickly. Seeing it in a diagram helps link theory to real-life practice. You might be the first one to notice the limb changing color or temperature, so trust your assessment skills and escalate concerns quickly. When managing fractures, neurovascular assessment is paramount. Frequent checks, elevation, and ice application are essential to prevent dysfunction. Common nursing diagnoses for fracture patients include risk for ineffective tissue perfusion, risk for complications, acute pain, and impaired mobility. Fracture management involves reduction and immobilization. This can be achieved non-surgically with closed reduction, casts or traction, or surgically with OREF or external fixation. This slide illustrates surgical management options for hip fractures, including prosthesis, ORIF for intracapsular fractures, and ORIF for extracapsular fractures. Intracapsular fractures often disrupt blood supply, increasing the risk of avascular necrosis. That's why a prosthesis may be needed. Extracapsular fractures tend to be more stable but still require surgical fixation. Post-operative care for external fixation requires meticulous attention. Neurovascular assessment, pain control, and pin site care are crucial to prevent infection. Cast care differs depending on the material. Fiberglass dries quickly, while plaster requires at least 24 hours and careful handling. Inspect the cast regularly for drainage, alignment, and fit. Assess neurovascular status and watch for signs of pressure necrosis. If a patient reports pain under the cast, especially burning pain, that's a red flag. You may need to request a bivalve or window for inspection. Pressure ulcers under casts can take weeks to heal. Traction applies a pulling force to provide reduction, alignment, rest, and decrease muscle spasm. Understand the difference between running and balanced suspension traction. Skin traction uses devices like box traction, while skeletal traction involves surgically inserted pins. Pin site care is essential to prevent infection. Skin traction is temporary and less invasive, but skeletal traction provides stronger force. Both require skin checks, padding, and regular repositioning to avoid breakdown or complications. Complications of traction include skin breakdown, non-union, neurovascular compromise, pin site infection, and immobility-related issues. This nursing reference guide provides a helpful mnemonic for remembering key aspects of traction care. Traction. The mnemonic includes temperature, ropes hang freely, alignment, circulation check, type and location of fracture, increased fluid intake, overhead trapeze, and no weights on the floor. It's a quick memory tool for bedside nurses. Hip fractures are a common concern, especially in the elderly. Understanding the etiology, often related to falls and osteoporosis, is crucial. This slide illustrates the different types of hip fractures and their anatomical locations, including intracapsular and extracapsular fractures. The fracture location determines the treatment approach and potential for complications. For example, intracapsular fractures may compromise blood supply to the femoral head, increasing the need for hip replacement. Clinical manifestations of hip fractures include external rotation, shortening of the extremity, severe pain, and ecchymosis. Chest and pelvic fractures can have serious consequences. What are some possible manifestations? Consider the potential impact on internal organs. These fractures can cause internal bleeding, lung puncture, or bladder damage. Monitor for hematuria, hypotension, dyspnea, or abdominal distension. Amputation involves the removal of a body part. It can be surgical or traumatic and affects both upper and lower extremities. In traumatic amputation, prioritize the ABCs. Control bleeding, wrap the amputated part in sterile gauze, and properly store it for potential re-implantation. Post-surgical nursing care for amputations focuses on monitoring for bleeding and tissue perfusion, preventing infection, and providing psychosocial support. Pain management is crucial after amputation. Distinguish phantom limb pain from stump pain, and utilize appropriate interventions, including non-opioid options. Mirror therapy, antidepressants, and anticonvulsants like gabapentin can help manage phantom pain, which may feel like burning or itching in a limb that's no longer there. Proper stump care is essential for healing and prosthesis fitting. This diagram illustrates the correct wrapping technique. Post-surgical care also includes ROM exercises, a firm mattress, and prone positioning to prevent contractures. Prostheses help shape and shrink the residual limb and aid in adaptation. Proper fitting, cleaning, and care are essential. Patients need support adjusting to mobility devices and lifestyle changes. Physical therapy is vital for strengthening and balance training. Outcomes for discharge after amputation include adequate perfusion, pain control, independent mobility, absence of infection, and positive self-esteem. Thank you for watching. Please subscribe, like, and share these videos with your colleagues.